This is, we can say, effect, and this is effect, yes and no. Then here we can say yes and no. Cause. And not necessarily cause. There can be any factor A, may not be associated. Or you can say factor B, right? Now, when I keep data over here, random data, 40, 30, and 10, and 60. If I have this data, then let us say how, what it could be. What can be inferred from such data? What are the likely things? So first, there could be some simple cross-sectional data with us, and then we can find out this factor yes or no. Just I say the urban rural, and then that we say that in that case the pain abdomen yes or no. Or here you can have a smoking, your cough yes or no, like this. So one thing is the cross sectional. Other thing could be case control study. So in this case, the disease will be over here, yes or no, versus agent causing the disease, maybe yes or no over here. In case of joint pain, if you keep it over here, then instead of agent, there will be multiple factors over here. Multiple factors like lack of exercise, and then the uh, diet, sleep, disturbance, so many things. Uh, Let me open up my video. So, in case of case control study, you start with a disease, those who are having disease. You also find out those who are not having disease, control. And in control is not necessarily not having disease, but you can have control like this. On one side, for example, you have joint pain, then control could be no joint pain and no other major illness. While here it could be no joint pain, but having some illness like diabetes, hypertension, etc. So it's not that when we use the case control study, there could be the, if you have taken 100 cases, it's not necessary you take 100 controls. You can take 200 controls also. Other thing is, you need not take only normal people, you can take other disease also as a control. So there could be 3 or 4 types control can also be there, and each may vary in the numbers. So that is a case control study. And once you start with the taking history of these cases, whether you had exposed to particular thing or not. In case of joint pain, we say that have you taken enough vitamin D? Have you exposed yourself to the sunlight or not? So exposure doesn't mean that it is always a causative effect. It could be a protective factor also. So in case if you have, suppose sunlight is a protective factor, then you should write over here lack of sunlight and sunlight exposed. You should write down is you should not take a literal meaning of the word exposed. Is it basically exposed to the cause, not exposed to the cause? Then the framework will look okay. Usually this cell, this 40 we label as A, this we label as a B, this data is C, and this is a D, so that you can uh, pull it with the book picture also. Right? Now, in case of cohort study, we'll start with this yes and no. For example, miners, person working in the mines and not working in the mines. And we see whether they develop silicosis, yes or no. That is the cohort study. In prospective and retrospective cohort study or combination of the cohort study, the main thing what you should remember that if it is a prospective cohort study, today you have two groups, yes and no. And then you follow up them for 1 year, 2 years, 5 years, 10 years. That is a prospective cohort study. But when you want to do the retrospective cohort study, you are doing the same thing, but assume that who were yes and no 10 years back. If some of them have died, then that history should also be included. If some of them escaped the study, some of them left the job, etc., everything you should be considering, and you should have a total flashback the 10 years back, or what was the 1 year back, or what was the picture 6 months back. So from whatever the retrospective when you are using, you should use your brain that what would have been number of people at that time exposed and not exposed. That's why, although the retrospective cohort study is very quick and it has a lot of advantage with the case control study is having quick and very easy to do, etc. But then it is also very giving a much better result than the case control study. The imagination that who were there at that time, that is the most demanding thing. Otherwise, if I want to do that 5 years back, my society, how many people were there, if I don't know, and then there will be a problem. So whenever you want to go for retrospective course study, you should have the picture clear that many years or that many months back. Then when you combine the retrospective and prospective studies, the retrospective you are doing it, and then now onwards you continue to follow the prospective studies, right? So prospective course study very good, but then is very demanding also. You should collect the data meticulously, time consuming and resource demanding. So this data could have come from cross-section study, case control study, cohort study, then it could have been from the randomized control trial. Control trial. For example, I want to the same example mines. It is not possible randomized control trial, but still hypothetically, I find out 100 laborers who are ready to work with the mines. So 50 randomized 50 people will work with the mines, other 50 will not work the mines, and still they are given other job like that. And then we follow them up for 2 years, 3 years, like cohort study. In randomized control trial, because we have randomized two groups, there is a least chances of the bias. Now, in randomized control trial, still better would be after 1 year or 2 years, you can do the crossover. And while you do the crossover, there is a likelihood that those who were exposed first, they may continue with the pathology in case of mice. But then there are other things like, for example, doing exercise, not doing exercise. And in that case, there won't be a hangover effect of the exercise, right? Or you are giving a particular vitamins, mineral, vitamin A, you are giving 50%, 50%, you are not giving vitamin A, and then follow up for the morbidity. After 3 months or after 6 months, you can do the crossover. This is possible. Other thing is, in the randomized control trial, what people do that we are dividing into three groups, for example. First group was given a particular intervention and follow up. Second group was given intervention after 6 months. Third group given another intervention after 6 months. Till then they are followed. This is also possible in randomized control trial, but you need to divide into three groups, four groups initial, and then randomly decide which group you will expose to what. Then there's another design in which you have, let's say, 1,000 questions, and you want to get from the 1,000 people. So you will have around 10 lakh answers, responses. But that is not required. So what do you do? That out of 1,000 questions, most important 100 questions you get from all the 1,000 people, but rest of the thing you divide into 10 groups, so that you need to ask another 100 questions to only 100 people. So that is also possible in one kind of study design, that you get information, a lot of information you want to get, but don't ask each question to all of them. Then the same data can be from Kappa study, where you are doing agreement between two things, two teachers, two clinicians, who test, etc. Agreement, what is the kind of agreement? And the same data, then we can have other idea also, that you are comparing the one statistical, one the laboratory test with other laboratory tests, or you are comparing X-ray test versus sputum ARP, or you are comparing blood culture versus the gram stain, like this. In this case, you may find out sensitivity,
Specifically.
specificity. You can also calculate positive predictive value,
Negative.
negative predictive value,
Odds
and
ratio.
also you can find out
Odds ratio.
false positive and false
Negative.
negative. So 2 by 2 table, when it is given to you, there are six kind of the analysis which you can do. But then if you want to, if such a data is there, if you want to apply a statistical test, whether whatever in the sixth case, whatever it may be, except in case of agreement, when you can go for kappa test, otherwise in agreement also, this is universally applicable standard error of difference between two proportion. This you can apply standard error of difference to proportion in this 2 by 2 table. There could be six types of the uh, the data can be there in this 2 by 2 table, right? And the calculation and formula for all this thing would be different, right? What we can find out here, you can apply chi-square test also in 2 by 2 table, right? And in AP info, you will be using the word tables command variable v1 versus variable v2. Suppose we want to find out the v1 is the age and v2 is the uh, illness yes or no, and v1 is the age. Is this appropriate that I should use table v1 v2, or this is not appropriate? Write in chat box.
Variables.
If I use this command in AP info, table age versus illness, is this appropriate command? Yes or no? Even Mansha, Soumya, Radhika ji, and what else? Four people, five is Mandan, Surbi. I need answer. I will not move ahead. No. Then what we should be using? If no is the answer, then we can't use the table command. Which command we should use? So we should be using command means of age versus illness. This we should be using in AP info. Anyway, we come back to our original things stuff. So If we are going to use, for example, the cross-section study, then simple standard of difference between two proportion will tell us whether there is a correlation between these two factors or not. But then, if we are going to use, what family, let me put it somewhere else. Suppose if we are uh, using a case control study, then in case control study, what we want to compare that out of this many diseases, for example, if we make a name a disease right now, a joint pain, and agent factor we call it as a the lack of exercise is a yes, lack of exercise as a factor. And we want to find out whether the lack of exercise was the factor in joint pain or not. So in this case, we need to find out how many were having this lack of exercise, right? Out of total 50 over here and here 90, right? And here all this also will be
Check you can replace.
somewhere else. Total is 70. Total is 70 over here. So in case control study, we don't look at this data. We look at only this data, 50 and 90. How much were exposed here and how much were exposed over here. That we are going to compare, and that's why we are not, we don't have the population over here. These are the cases in control, and we don't have the pop. We have not started with the 140 individuals who are having a lack of say no lack of. We started with this number of cases and controls. So we don't have a population because we don't have a population. We don't have a risk estimate. We don't have a. We can't calculate that the number of incidents. We can't calculate the prevalence. We what we can consider is a number of people who were exposed to particular condition. And that's why we can't have relative risk in case control study. So what we will have ratio of odds. That we say that odds ratio, right? And in that case, we can see that what we do, AD divided by BC. A into D divided by B into C. Right? This is how we derive it odds ratio. In this case, if you consider, it will be 16 to 40, 2,400 divided by 300. So roughly it is around 8. So you cannot say that exactly 8 times it was the higher, but it is relatively more exposed, our people are having more disease, that you can conclude. But if this is the same, this is suppose it's a cohort study, then in cohort study you can definitely find out the relative risk. What is the risk in this case? Lack of exercise risk is 40 out of 70. And what is the risk in other group? It is a 10 out of 70. And this we sorry.
Exercise.
10 out of 70. So in this case, we can definitely compare. What is the risk here is 40 out of 70 is a 10 out of 70. If we take a relative risk, it will be 40 upon 70 divided by 10 upon 70. 70, 70 will get deleted. So the answer will be 4 times. The answer is 4 times is the risk, relative risk. So those who lack the exercise, they will have the 4 times more likely to get the disease. This is how it will interpret. Then, more important in a public health will be if a people start doing exercise, how much risk of joint pain can be reduced. I repeat, if the people starts doing exercise, what will be the reduction in the risk of the joint pain? So in this case, what you should be doing that even if those who are doing exercise, they are having some kind of other reasons because of their they are suffering from joint pain. So these 10, they are suffering from the uh, joint pain, even though they were doing regular exercise. Even the factor was not present, they were suffering. So what is an excess? How much you can reduce? So you can, if this 10, you can reduce. If you convert into the percentage, it will be much better that the answer will be much better. So what you should be doing, the incidence in expose minus incidence in control divided by incidence in control. So, expose. So what essentially we are doing that we are removing this factor. This you should be closely understand that here in this case, out of 40, I'm right now doing absolute figure. Otherwise, you should be taking percentage. But because denominator is same, right now I am taking the liberty to take it directly. Otherwise, we should be taking percentage and we should calculate the risk and then we should doing this, right? So 40 minus 10, so we'll get absolute value. That the factor out of this 40, 10 is contributed by other factors. So remaining absolutely contributed by the absolute contribution of the lack of exercise is 30. 30 out of 40. So you can say that the 75% reduction in the joint pain can be done if we start doing exercise. But that 25% which is remaining, that we need to search out what are other attributable risks. So attributable risk, if you want to find out total problem in the exposed people, do the minus the control factor so that you remove that and you get what is the contributed by the factor. So it's something like that. Your child, you are giving 100 rupees and he is spending something like, let's say, 150 rupees daily. That means 50 rupees is bringing from somewhere. So your contribution is 100 out of 150. So it's around 30, 66%. It's like contribution. When we use the word attributable risk, the word actual meaning is how much contributed by the particular cause. So this is something about the uh, attributable risk. Now, the the same thing when we talk about the sensitivity, specificity, etc., is also can be done on the same uh, table, provided we just need to change this over here. We need to say that the gold standard, the test known as gold standard, I will remove something over here. we here. There are six parameters. If you just pay attention for 10 minutes, you will never forget in your life. Now, this is a test and a study. Test to be evaluated, and this is a gold standard test, right? We say gold test. It could be something over here. Let's say here we can ELISA test. You can here say the PCR test. You can keep it over here. You can say put on the biopsy. You can say result or postmortem result. You can say here the biopsy. If it's a postmortem, here's a biopsy, right? Or it could be the blood culture. It's a gram stain like this. So we want to evaluate and we want to find out the sixth parameter over here, right? Sensitivity,
Specifically,
specificity,
positive value, negative value, positive. Mm.
then positive predictive value, then we want to say negative predictive value. We want to find out false positive and false negative. Now, sensitivity. Even a slightest stimulus is there, the person is very sensitive. हम थोड़ा बोलेंगे तो भी वो हिल जाएगा. Very sensitive. So in that means the test is the ability to find out even if there's a minor presence of the disease, it will find out. So actually the gold standard was telling that 50 people are positive and the test was able to find out 40 out of that. So sensitivity means the 40 out of 50 and then to convert into the percentage, you multiply by 100,
80%.
right? So
Percent.
that means it is sensitivity is 80%. 80% of the cases this test is able to find out. Now specificity, very choosy. Nowadays children are very choosy. Yeah, I don't want this, I don't want to have this. Very choosy. So the if test is very choosy, it will say no if it is not there. No if it is not there. So ability of test to detect, our ability of test say no if it is not there. So this test in our this test could say how many is can know out of 90 it could detect 60 as no. So specificity it will detect only if it is there, right? 60 out of 90 it was it could detect nah yes you are not having the disease. So this is a divided multiply 100, that is the percentage of specificity. This will be something around 6 upon 9, 2 by 3, roughly 66% or so. So specificity is 66%. Now, your positive predictive value of negative predictive value. Now, positive predictive value means if test says that 70 are positive, what is the likelihood that the person will really have the disease? So it will be 40 out of 70 will have a positive predictor. If this test says that you are having a particular disease, in fact, the really the person will have the disease is likelihood 40 out of 70. Multiply 100%. So 4, so 15, it will be something like 56%. So if this test says 100 people, yes, you are having this disease, only 56% will have that disease. Reverse way. If this test says that no, these 70 people are not having disease, actually how many are not having disease? 60. So what is the likelihood that when this test says no, really person will not have disease? That is 60 out of 70 multiplied by 100. 60 out of 70 multiplied by 100, right? That will be somewhere around 6 upon 7, something like 84% or so. That is the negative predictive value. When it says yes, you are having, less likely that the person is having. It says that you are not having, more likely that yes, it is not having. 84%, right? Not having. This is negative predictive value. But now we talk about false positive and false negative. Now I just give you a simple hint that even at midnight 3 p.m. or 3 a.m., so midnight 3 a.m., people say that what do you mean by false positive? What do you mean by false negative? The word which you should be using is falsely labeled as positive, even though it is negative. This is a word which you should be using instead of false positive, false negative. Take a deep breath. Just pay attention for 1 or 2 minutes here, and you will never forget false positive, false negative. What we should be using the word falsely labeled as positive, even though it is negative. That is a false positive. And false negative means falsely labeled as negative, even though it is positive. Now, even if you want to forget, you cannot forget if you remember this. How do we spell it out? False positive instead of that, falsely labeled as positive, even though it is negative. So in our case, these are the total 90 are negative. Out of them, how many are falsely labeled as positive? This 30. These 30 are falsely labeled as positive, even though it was negative. So we can say that 30 out of 90, 30 out of 90 are labeled as positive, even they were negative. So we can say that 30 out of 90. And percentage, if you take, it will be something around 34%. Then positive labeled as negative, even though it is positive. Positive labeled as negative, these 10 are labeled as negative, even though they are positive as per the gold standard. Right? They were falsely labeled as positive, labeled as negative, even though as per the gold standard, they are positive. So it is falsely labeled as negative. That means falsely labeled as negative, even though it's positive. So what is the number? 10 out of
9. Okay.
10 out of 50. So it is 20%. 10 out of 50. Small I'm just putting because it doesn't take the days. Anyway, so it is a 20%, right? So now here you are supposed to make the what cutoff line you should be taking. If you want to adjust sensitivity and specificity, cutoff line may go something like this, right? Or maybe go like this. So as sensitivity increases, specificity decreases, and specificity increases, sensitivity will decrease. This is likely. So we need to select a cutoff line in such a way so that you get the maximum yield. And I would say that if you have liberty to use a non-invasive test, then you go for a cutoff line in such a way so that the same test by taking cutoff line 1 you are getting maximum sensitivity. By using another cutoff line, you are getting maximum specificity. And between these two cutoff line is a borderline population. And you follow the borderline population and then go on using another non-invasive test over a period of time. Or you combine another non-invasive test, or even you talk about invasive tests, you combine the two invasive tests, for example, or two laboratory tests, for if you combine two different tests or two serial tests, the same thing, then definitely you will be able to mostly increase the sensitivity and specificity. And that the combination of a probability, if we'll talk about how we can uh, change the probability of the same test using the sensitivity and specificity are different the cutoff lines. Now before I proceed, you can see that the sensitivity and this 20%, right? So falsely labeled as negative, and this is falsely labeled as positive. You can see that the total will be 100%. This false positive and specificity, if you combine two things together, it is 100%. And if you false negative and the sensitivity, if you combine, then it is 100%. That means that if sensitivity, if you want to increase the sensitivity, then the false negative will reduce. If you increase the specificity, then false positive will get reduced. So if you have a borderline to choose, go for 98% sensitivity, go for 98% specificity, and for those who are in the borderline, follow them. This is how in a public health you should be doing. Now, if a question is in community, when you want to go, you have a choice of when you go into the community, you have a choice, and you will be asked whether you want to go for a high sensitive test or high specific test in community. You have to choose one. Suppose price is same for both the kind of thing. So what will you choose? Give me the answer. Highly sensitive test or highly specific city test in community you will be using for a community program. Tell me the answer. Sensitive. Okay. Any other answer? So this is the correct answer. Because if there is 1,000 people, try to use most sensitive test so that you can find out almost all the people. Let's say out of 1,000 you have found out 900, right? Suppose almost all the cases you have found out of 1,000 population, you have found out 900 positive, right? For example, whether the people are taking outside food or not. This is a simple question. You want to find out the maximum people, or you want to find out, let's say, the exact BMI, right? In case of obesity, if you want to find out, you could find out all the 100 cases of obesity, in which you should not go for the more than 27 or more than 30. Even if they're more than 25, you consider them as obese. So you find maximum people. So 100 you have found out, and out of that, you go for a highly specific test. At that time, you get a cutoff line of 27 or 28. So there you can say out of 100, 80 were having obesity, really. So 20 you can keep as the under observation, or you can go for highly specific test. So in this case, obesity you are not measuring by the weighing machine. You don't have a height scale. You just go for this mid-arm circumference tab, and you based on that you go cut off line such a way so that maximum you can find out. In this case, now you have only 20 for observation where you should be using high test, for example, take exact height, take exact weight, and all those things. So don't waste money. After all, if you use statistics and epidemiology sensibly, you will save thousands crores of rupees of our country. And there could be a syndromic approach. You can develop a syndromic approach. I will give an example. You are going for syndromic approach, for example, the Chandipura virus right now, which is existing, right? So in that, you do the overdiagnosis. Even the small symptoms is there. You say it could be Chandipura. You don't tell to the community or people, but in your format, you say this likelihood of a Chandipura. And when you go for highly specific test, out of that, you will have Chandipura. Rest are under the operation. This is how we should be deploying the test so that you need not cover so much population. So highly sensitive test first and then high specific test to start the treatment. Then, so we will, this 2 by 2 table, sensitive, specific, etc. will quickly go through the case control and cause study, summarizing the things. I will just stop here. But, let's see. It is very simple, but it is worth going through once.
Repeat.
So, uh, we'll quickly revise the case control study. The distinguished features are exposure and outcome. Outcome may be the disease or some other kind of outcome can also be there. Already occurred before the start of study. And study process backward from the effect to cause. Effect is already now we are saying whether cause was there or not. So there could be a memory bias or recall bias like that. And the comparison group we are using those who are not having disease, right? So this is a control study. We select the cases first, then controls either from the hospitals or vicinity or neighborhoods or the relatives, right? We match them for the age, sex, etc. We measure the exposure by the recall, of course. So calorie was taken more or less like this. In this, if you have, let's say, obese people, and if you have very thin and lean people, and you ask them today about their diet, naturally obese people will have a low calorie diet, and the thin and lean people will have more calorie diet. But if you look at the past, what was there in last 1 year, if you ask that, then you will find. So exposure doesn't mean what was happening 2 days back, right? You should go into that depth. And finally, analysis and interpretation. So, cases, your diagnostic criteria should be very well. Go for the eligibility criteria, a specific age group, or there could not be other the diseases together like that. You get it from the hospital general population, and when you select the control, it doesn't mean that it cannot have other diseases, but that same disease they should not have. That is a very important, right? And rest of the things almost same. Sources we already talked about, and although it says that 1:1 ratio, but 1:4, 1:6 also is possible when the cases are relatively less. We do the matching, do the measurement by exposure, and in case of, let's say, you want to do the food analysis, you can have a weighment method, stock inventory method, a lot of methods could be there. And at the end, you will have AD upon the C, or exposure among the cases, or the exposure among the controls. So that is the actually odds ratio, odds needs to think of A upon A plus B, and the C is C upon C plus D that we are taking, and then the actually the AD upon BC will come, right? So this is a in nutshell case control study. Now, if you look at the cohort study, here we'll have the two groups will have, right, or three groups or four groups exposed to a risk factor, not exposed to risk factor. We can take four, five things also. The people are taking vitamin C, people are taking amla, people are not taking either of them, people are taking some other kind of magnetic water. You can have six or seven kinds of groups, core groups. You can think of the 100 patient of diabetes treated under the allopathy, 100 patient treated under the magnetic water, 100 treated under the allopathy, the other homeopathy and Ayurveda, etc. And then you could follow them up. This could be a core study. Or that's in case of a treatment evaluation. Otherwise, if you look at the reasons, right? We can have something people in the Rajasthan, in the Gujarat, in the Maharashtra, like this. Geographical groups we can take, or we can take group according to exposure to the smoking, then taking the tobacco chewing, and none of them. Three groups you follow them up for the cancer, etc. So we have identifying first the group, right? One group, two group, three groups. We follow them at a regular interval, let's say every 15 days, every month, like that. And then, so this is a prospective study cost to effect, right? And there could be multiple risk factor also, and multiple disease outcome can also be there. But usually it says that we take one risk factor, one exposed, but we can take combination of the exposure also. But in this case, disease could be more. In case of case control study, we can ask multiple exposures also. And in both the time study, multiple risk factor and multiple disease can also be there. But because in case control we are starting one case, usually we take a single disease. And because in core study we start with the one risk factor, this is only one and disease can be multiple. In the type of core study, prospective core study, in which today onwards we are going and finally finding out over a period of 1 year, month, 1 year, 2 years, that whether disease outcome is there or not. In retrospective cohort study, we find out what was there few years back, right? Researcher goes back in time to select the study groups from past records. It is a tedious, but we need to find out meticulously. And if we combine, we go back and also follow them up the in future. That is a retrospective come prospective studies. Now here we are selecting the study subject, exposed or not exposed, right? And then we'll find out the for during follow-up whether the disease outcome is there or not. And groups could be a students group, employee group, volunteers. Such groups can be there. Then there is something like the industry or occupation. Even directly you can say the sugarcane workers versus gully tap workers, sewage workers. There could be several groups. And you go on asking them at a regular interval whether we can find out a particular disease or not. And sometimes there could be internal comparison also. So you have a data available of the exposure, you have data available of the outcome also. So that comparison we can also have. And then in analysis, this is most important because here we have a number of population beforehand. A plus B, out of that A, and C plus D out of C. Both we have exposed and not exposed. Both we have. So out of this population who were exposed, how many suffered? Out of this population who were not exposed, uh, how many had developed the disease? So we have the risk ratio is available. IA1 IO. And if you want to find out the attributable risk, you minus this from the exposed and you will get the attributable risk. So this is case control in cost study. We'll have few minutes for the question answer. I'll stop saying. I will, before you ask any question, just listen that one side is tea versus alcohol. Here, 2% people are having alcohol. Here, 90% people are tea. Now, this data is available with you. And let's say, health commissioner is talking to you that what is the population attributable risk. Risk is more for alcohol or for tea. Can you give me the answer quickly? Population attributable risk will be more in the case of tea or in case of alcohol. Very tricky question. In the disease, I will tell you very simple disease of acid peptic disease. Acid peptic disease. For APD, which one is more uh, population at risk of tea or alcohol? Can anyone give the answer? At least one person should give me answer. You need to write only yes or no. Whatever you want comes to your mind, just write down. Tea. Oh, alcohol is so much dangerous. You are talking about the tea. Anyone? So actually, we need to find out the what is happening to the population who are taking tea, what is happening to the population who are taking alcohol, not taking tea, and then we can calculate those things. But in general, we need to see the two factors. If it's purely because of tea, what will happen? Purely because of alcohol, what will happen? Let us say that is factor X1, X2. Then you multiply by what is the prevalence of that factor in the community. That's the Y1 and Y2. That combination of that will talk about the population attributable risk. That means in community, if you remove the effect of E, or in the community, if you remove the effect of the alcohol, you remove those things, what will be the changes in the society? And that is the population attributable risk. So in what we say that what is the total population having the problem in the total population minus problem in those having that particular factor divided by again uh, prevalence in total population. That will tell you that ultimately what is the population attributable risk. Right? So, any question? I hope all of you have seen the uh, protocol, PPT on the protocol. You are probably given all the folder, Google folder. You go to the Google folder on Thursday. At least I expect protocols from some of you.
Hello, sir.
Any question? Yeah.
I have one small question. How to
Yeah, please.
interpret odds ratio?
So interpretation of the odds ratio, there are two things. In general, suppose it is 2, 3, 4, 5 like this, right? Then you can say that they are related. But in odds ratio also, there is a test by which you can find out whether it is statistically significant or not. That is, advanced statistical tests are available for that. But for a simple thing, 3, 4, 5 means approximately 3, 4 times like that. It is not exactly like that. But as odds ratio increasing 3, 4, 5, 6, 7, if you look at the risk, also will increase 3, 4, 5 like that. So it is not exactly the same. So you just say that if odds ratio is 1, there is no association. If odds ratio is 2, 3, 4, that increasing the odds ratio increases the association between two factors. That's how we interpret the odds ratio. But if you want to find out whether it is statistically significant or not, then it is much better that why we have taken a seven or examples in 2 by 2 table. Directly go for statistical test whether the difference between two factors is statistically significant or not. And the advanced test will tell you there's odds ratio, what is the 95% limit of the odds ratio. That also can be calculated. But for our purpose, we go for p-values, the tables command in the AP info, tables, illness, the tables command, then whether what kind of food you have taken and disease. Tables command, excessive sugar, diabetes, like this. Any other question?
Hello, sir.
Yeah, please.
Yeah, I have a question. You just mentioned about the population attributable risk that tea
Hmm.
drinkers 90% and alcohol drinkers 2%. So just by looking at this, we cannot interpret the
No,
population
no,
attributable risk,
we
right?
can definitely not, we cannot interpret based on simple data, but we need to look at the harm caused by the tea, harm caused by the alcohol. Suppose both are 50-50%, suppose, then naturally we can say that alcohol population will be more. But some generally people say that tea is safe, alcohol is causing more problem. So say that yeah, alcohol should be having a more population risk. So we need to combine two things, prevalence and individual risk. Two
Okay.
things together, then you will give a population risk, and that's why a study is required for that.
Okay.
Because if directly looking at the data, we cannot judge. Suppose if T is a 40%, alcohol is 30, various permutation combination will be there. So individual population attribute should be taken versus prevalence in the population. Then you can find out population attributable risk. And the study has to be conducted on that.
Okay. Yes. Thank you, sir.
Yeah, any other question? So I expect all of you on Thursday, with at least before the Thursday, if you can just start putting in the group about the your project proposal or protocol, that will be much better. And if you have not seen the sensitivity and specificity video, you go through it, it will be very useful. Thank you all.